Hello, good evening, everyone. Welcome to my MVF&x and the European Fertility Society. We are back once again with Dr. Elias Tsakos. You can see him right here. Hello, Dr. Tsakos. Lovely to have you as always. How have you been? Busy day, I know, but I hope that you are ready to discuss our topic today.
Absolutely, absolutely. Thank you so much for the invitation. I mean, it's 9 in the evening here in Greece. It's been a very long day. We all start here at Embryoclinic at 7, so it's been an amazingly long day, but hopefully I will have some information to share with you and our audience.
Perfect. We are definitely ready to hear what you will talk about this topic. Of course, secondary infertility. This is what we are focusing on today. Let me just remind everyone that Dr. Tsakos is the medical director at Embryoclinic in Thessaloniki. So we are happy that you got time and we will be able to explain to us secondary infertility, the causes as well. And of course, we are really looking forward to the presentation. But afterwards, there will be time for your questions. So please put those in the chat as always. And remember, it's all anonymous and we are simply here to help you out as much as possible. So simply don't hesitate, okay? Now let's go ahead with the presentation. I believe you can see it and we can start.
Sure. Thank you very much, Caroline. I will try and keep it short and sweet. My presentation is not going to be longer than 20 minutes. I have changed the model of my presentation. It's very simple and bullet point type today. So hopefully I will try to pass on some messages on to the audience. I can see some friendly faces there, and thank you so much for being there. Now, secondary infertility, what is it? The definition varies a little bit. Some people believe it's the infertility after a successful pregnancy, but some papers refer to secondary infertility as difficulty in conception, even after a first conception but unsuccessful pregnancy, so a miscarriage. So all in all, basically it refers to cases in which they have achieved a pregnancy, usually with a good outcome, but now they find difficulty in achieving a second pregnancy. So this refers to patients, to couples, or to single women wishing to have a second child. Now, all I can say here is from my experience, these are the most determined cases. Many of our cases, many of our patients, of course, are struggling to achieve the first baby, and most of them are very motivated. However, in my experience, the motivation is perhaps 10 or 20-fold for couples or single women who wish to achieve a sibling. And my explanation is the fact that they have experienced the joy and the pleasure of being parents, and of course doubling this happiness is making them even more keen. So it refers to a huge number of patients. I have to remind you that in Europe the average fertility rate is about 1.4. So on average, most women have very near one child as opposed to 2 children. So I believe that the numbers are much bigger than we think, because I believe that a lot of these women, either single women or in relationships, they don't come forward, and perhaps they waste a lot of time believing or thinking that, okay, it came to me once, naturally, usually, and I might as well wait and it will come again. And of course, it doesn't come. So I think we have to clarify that. So it affects a lot of couples, either couples who have conceived naturally or via artificial technologies. And of course, it's failure to conceive after about 12 months. Now, about 60% of cases, although I believe this is probably more, because this statistic came from fertility units and from fertility gynecologists. And whereas in actual fact and in practice, there's a lot more women who don't even present themselves, a lot more couples who just let it go after having tried for a few years. And of course, this trend is becoming even higher, increasingly higher, due to the delayed childbearing in the first pregnancy. And of course, it's very common in all populations. So why is it happening? And there's a lot of factors here involving either the female, the male, or both. And this could either be a pathology that was present in the first place. So, for example, a couple who conceive naturally with perhaps a little bit of a low sperm or a little bit of a tubal factor. And when I'm saying a little bit, I mean a mild or moderate semen analysis factor or tubal factor. They may have been lucky and they conceived when the couple were in their late 30s. But then in the early 40s or mid 40s, this is becoming increasingly more challenging. So which are the major female factors? That affects the anatomy, which is the tubes, the uterus, the ovaries, conditions like endometriosis and myomas, and most importantly, the age. If you ask me, the single most significant denominator of fertility is the age. And the age reflects and refers to both female and male age. Let's not forget the male age. Men over the age of 40 are more likely to have sperm problems. And even if we manage to overcome those problems and achieve a pregnancy either naturally or via assisted technologies, the problem is there and usually gets augmented with age. Let's not forget that. Now, one of the very important questions I ask my couples, and perhaps you could ask yourselves if you're listening and you're affected by this condition, is this: how long did it take you to achieve the first pregnancy? And very often I find that they say 2 years, 3 years, 5 years, 7 years, 10 years. It's very uncommon for those couples with secondary infertility to say, oh, we conceived within 6 months of trying. So my impression and my clinical interpretation of this fact is that there was a mild to moderate infertility factor, and of course that was overcome because of the younger age. And now that it's confounded with the advanced age of both men and women, that underlying factor has become severe. It's making it even more difficult. So age is a huge factor. Male factors, let's not forget men. Let's not forget that male infertility affects roughly either as a sole etiology or an associated etiology, perhaps 50% of our couples. So let's not forget that. Reduced sperm count, obstruction, infections, lifestyle causes, and of course the advanced age. The advanced age, we very often see men in the late 40s or 50s or even 60s. And even with the normal semen analysis, let's not forget that the semen analysis is only one factor. You know, if I want to give you an example, it's like watching somebody walking. Yes, they can stand, they can walk. That doesn't mean they can run. It doesn't mean they can compete. It doesn't mean they can achieve a pregnancy. So there's a lot more tests that are indicated for men, especially when we're referring to men of older age, of advanced male age, in order to identify the fertilization potential of the sperm. So combined factors also play a huge role. This is what many people call unexplained infertility. I will be very clear here. Most of unexplained infertility causes, if we look deeply into them, we can explain. It's just a very convenient term to bucket in a lot of cases when we don't want to investigate further and when we want to just cut corners and go straight into IVF, 𝐾𝐨 or whatever. In my opinion, this is wrong. In my opinion, in this day and age, we owe our Hippocratic oath to investigate more. And I'm not talking about going over the top, but the more we investigate, the less unexplained infertility factors and cases we will identify. Now, tubal causes a lot of, tubes are very sensitive organs. They may be affected by infection, by adhesions, by ectopic pregnancy, by ligations, and even by adhesions which may not become evident. We have a lot of means of assessing the tubal factor. My team and I are very fortunate and very happy to have presented and to have published recently a very good study on the efficacy, on the accuracy, on the safety, and of course on the value of the ultrasound, the hydro ultrasound foam salpingography, which is a very straightforward outpatient procedure, which may give us very good details about the tubal condition in the majority of cases. And of course, we measure that against the traditional method, which was the X-ray. So in this day and age, with advanced ultrasound scan machines, with advanced technology, with 3D and 4D ultrasound scans, with high FOSI, with markers of endometriosis and so forth, I think we should be able to diagnose perhaps more than 95% of tubal causes without the need of performing a laparoscopy, for example. But if we do, then that is also important. Let's not forget that a laparoscopy and hysteroscopy in the old times, in my times in the 90s, was an absolute prerequisite before IVF. Uterine causes, very important, seriously overlooked. Most of you, I can see some very friendly names and very familiar names in the audience. The uterus is not just the dimensions and the size of the endometrium and perhaps the shape. There's much more to the uterus than that. And again, with advanced ultrasound scan technology, which sadly is not available in many IVF clinics, never mind standard gynae outpatient clinics, we can diagnose those situations like adhesions, fibroids, polyps, even cancer. In my practice, we diagnose 1 to 2 cases of endometrial cancer in patients who just come for IVF, just to give you an idea of how frightening this can be. And of course, the vast majority of these cases can be diagnosed by clinical examination, history, clinical examination, and advanced ultrasound scan. So for any of you out there, please demand from your IVF specialists, from your gynecologists to offer you this technology. This technology is there for this particular reason, to diagnose correctly the internal pelvic pathology of women. Now, another very important factor that I'm very passionate about is chronic endometritis. Again, this may be able to be diagnosed by scanning, but sometimes it's not. Performing an outpatient hysteroscopy is again very straightforward, very non-invasive solution with a little bit of local anesthesia, no anesthesia, a little bit of sedation. We can look inside the uterus with expertise, with experience, with high resolution hysteroscopic technology. We can accurately diagnose that clinically. But again, by taking some biopsies, either general biopsies from the endometrium or directed biopsies from lesions, we can diagnose other conditions like chronic endometritis. We can check for biopsies. We can check for histopathology. We can also check for microbiome testing. These are the absolute gold standards, in my opinion, if we want to accurately diagnose the condition of the endometrium. Many people ask me about natural killer cells. There's a lot of science missing there, but yes, we would check for that as well, given the limitations. If we're taking a sample, we would probably check for that also. And then we would sit together with our pathologists, with our microbiologists, with our immunologists, with our colleague gynecologists, and the patients in order to identify whether some of those factors are detrimental for normal pregnancy. So the endometrium, the soil, is very, very important. My team and I are now working on advancing ultra high definition spectrophotometry, which is a technology that has been developed in Greece by some very brilliant people in the University of Crete. They have incorporated that technology in the colposcopy examination, and now we're looking into the possibility of of using that for endometrium and hysteroscopic appearance. What does that mean? It means that even inexperienced hysteroscopists, with the use of technology, they may diagnose pathology, which may be detrimental. Okay, moving on. Ovarian causes, ovarian reserve decline. This is perhaps most often the case. Sadly, today we had a case of secondary infertility, a couple who conceived naturally about 4 or 5 years ago, 4 or 5 years of infertility. In the meantime, premature ovarian failure was diagnosed, an AMH of 3 picomoles or 0.4 nanograms, very low AMH. We would expect this AMH in a patient perhaps 10 years older than this particular patient, and who only gave us 2 eggs of bad quality. So age, and everything else. I think these are the reasons for most of the fertility issues. But on the other part of the spectrum, we find polycystic ovaries and polycystic ovarian syndrome, especially when it's not managed holistically. Then we see either an ovulation or bad ovulation and so forth. And of course, a lot of imbalances many times may be the cause of secondary infertility. Endometriosis, that's one of my passions. I'm not going to go deeply into that. It's a chronic disease, affects 10% of the general population and up to 50% of infertility population. And certainly we need to have an eye to diagnose endometriosis. The more we study endometriosis, the more we diagnose. I've had numerous of cases. I have cases every week where women have been scanned, have been seen, have been counseled elsewhere, and they were dismissed as no endometriosis, and they have very visible either adenomyosis or deep endometriosis, or even if we can't identify that, we can see some signs of peritoneal disease. So, always wonder, even if you don't have symptoms, infertility may be a manifestation of endometriosis, of undiagnosed endometriosis. I've had countless women in their early 40s who were diagnosed for the first time for endometriosis, having suffered with menorrhagia, with pains, with ovarian cysts, and so forth for many years in the past, and infertility, of course. Male factor, the new kid on the block, male infertility. Thankfully, a lot of bright and brilliant scientists are now working in this field and are trying to give us some idea about the male factor infertility. I have to accept and I have to admit that for many decades, gynecologists, we have ignored perhaps the importance of male factor, maybe due to the fact that we thought we could overcome this with 𝐾𝐨𝐧'𝐭. This is not always the case. A bad sperm, a bad DFI, bad sperm with oxidative stress, even with 𝐾𝐨𝐧, is associated with adverse outcomes. So we have to look very carefully into that. Lifestyle, very important, very important. I cannot stress how important it is. I know it's difficult for everyone. We all have our little addictions. Mine is workaholism. So it's very difficult. We have to address it. Perhaps it's not our job. We're not very good in addressing it as gynecologists, fertility clinics. We need a team. At Embryoclinic, we have a team of counselors, psychologists, fertility specialists, coaches, trying to look into that. It is very important because especially when there's mild to moderate factor infertility, a very small, very moderate lifestyle change may make all the difference. And please remember out there that number one aim is to improve your overall health so that you achieve your pregnancy naturally. We're not here to offer IVF to everyone. The joy in our unit is multiplied by a factor of 10, 20, 30. If with very small interventions, either counseling, coaching, lifestyle interventions, vitamins, some advice on fertile days, some reassurance, perhaps a little bit of surgery sometimes. We have helped our patients to achieve a pregnancy naturally. And please remember that if a couple achieve a pregnancy naturally, then the chance of this happening again is pretty high, provided that they don't spend a lot of time in between. So evaluation, I mean, that goes without saying, more or less I've said all that. I'm still very surprised when I receive couples from other units or from abroad who haven't had, very basic, very essential investigations to my mind, such as a full hormonal profile. I mean, the chance of thyroid disease overall in fertility patients can be as high as 20%. And that cannot just be diagnosed by TSH. Sometimes the TSH on the day of the measurement may be normal, but they may have abnormal antibodies and so forth. So these are the very standard tests I think we should be considering. And most of them are non-invasive. And equally for men. I have to stress again here that all my patients, when they undergo assessment, they have essential testing for karyotype, for cystic fibrosis, for thalassemia, plus advanced ultrasound scan. The men have, by definition, they have a semen analysis, they have a culture, and they have a DFI to start with. And we're very surprised. We have been very surprised initially, perhaps 10, 15 years ago, when the knowledge was saying that, oh, if the semen analysis is normal, no need to do DFI. And even in the early days of the DFI, we identified many men with normal or almost normal semen analysis with abnormal DFIs, which can be very easily controlled with vitamins and lifestyle changes. So additional testing, I'm not going to go into that in very much detail. The principle is to treat the underlying cause, to optimize all the comorbidities and the lifestyle factors, perhaps to promote timed intercourse, surgical correction if you need to, and of course, assisted reproduction technology as a next step. We have the whole plethora of ART that we can apply, and most of it with very high levels of safety and success. And the prognosis, of course, depends on the age, duration, cause, whether we intervene early or not, and whether we have been supporting those patients holistically. If I want to make a small comment here before the take-home message, this is that since most of our couples, most of our even single women, presenting with a secondary infertility, there's a confounding factor of age-related infertility. What we have observed, and we're just about auditing that now, is that those couples where, for example, the woman is in her late 40s now, having had either a natural or an assisted pregnancy at 42, 43, they are so determined to have a second child that they move more easily to egg donation or sperm donation than couples or women who haven't had a single child yet. So this is a little bit of not something that we would expect, but if anything, that shows to me and to our team and to you as our patients how determined these people are to become parents and to create a sibling for the child, their only child. So take-home message: secondary infertility is very common. Numbers speak for themselves, and I believe it's commoner than we think, because a lot of couples, they don't come forward, they don't visit, they accept the fact that they will be left with one child. It requires a systemic evaluation of both partners, and the positive fact is that most couples would achieve conception with appropriate management. So this is my take-home message. I think I'm in time, so feel free to ask questions.
Brilliant. Thank you so much indeed for walking us through all aspects, of course. And this is a big discussion, and I'm sure you will have lots of questions. And there are some questions in the chat already here. So let me show you the first one, because it's actually the longer question. Okay, so let's have a look. I have had 2 successful natural pregnancies followed by 4 early miscarriages in the last 12 months. Just turned 40, AMH 17.2. No IVF treatment today, just investigative testing. All standard testing were okay. We had LAD blood test recently, which indicated extremely low B and T cell levels. I have been advised to get LIT treatment, but I'm cautious given it's an alternative treatment. Could this really be a significant issue for me after 2 successful natural pregnancies with my husband? And would you advise pursuing treatment? Yeah, I am getting hysteroscopy, laparoscopy next week as well. Okay, for suspected adenomyosis, endometriosis. How soon after can I try to conceive?
Hi, Jenny. I mean, this is amazing. You know, your history summarizes more or less my talk. So if I want to highlight, and thank you so much for sharing your personal information, and congratulations for going for a 3rd pregnancy, which I very much hope you will achieve. So what are the important issues here in your history? Firstly, what I've already mentioned, that you know you had a difficulty in achieving the 1st pregnancy. So 4 miscarriages. 4 miscarriages indicate that by definition there was a mild to moderate factor in fertility anyway present. So that's one factor. Second factor that I can see here is that you know you've done the standard testing, but you know we're not sure how do you define that. So DNA fragmentation of 21%, again, you know, probably on the high side, depending also on the age of your partner. If he is over 40, that may be even more significant. I think it's a good thing that you're having a hysteroscopy and laparoscopy. I think it's a good thing that they have suspected endometriosis, exactly what I said a few minutes ago, that some women in their 40s, they diagnose their endometriosis. I think you're doing very well to proceed with that. Overall, in view of your age and your history, I believe that the highest chance of pregnancy would come from IVF plus or minus 𝐾𝐨𝐧'𝐭, IVF/𝐾𝐶 with pre-genetic testing. That's the quickest road to pregnancy. And if I can justify myself, I would just say this. At 40, hopefully one would expect you to produce 4 to 5 eggs, hopefully a couple of good quality blastocysts. Statistically, one of them would be PGTA normal. And if you implant that with the appropriate support, taking into account the 4 miscarriages, which would probably need a little bit of investigating, that will give you the chance of success of a 35-year-old, 33-year-old perhaps. So in my opinion, this is the quickest way to pregnancy. Of course, you know, there's the logistics, the finances, the accessibility, the waiting list, and all of that. But that would be probably the quickest road to pregnancy.
Okay, thank you for your advice. And if there's anything else, you know what to do. We still have time for more questions, so go ahead, type this in. Now we will go back to the previous question again from Christina this time. And here's the question. I had an ectopic pregnancy in 2019, age 32. We waited 6 months as suggested, and 2 months later we conceived naturally, had a healthy pregnancy, gave birth to a healthy child with C-section before turning 34. Now I'm 38 and have been trying for 1.5 years. We have been visiting fertility clinics Germany since March. My case is low AMH, Hashimoto, age 38. According to the doctor, started an IVF around a month ago. During the egg retrieval, 4 follicles were collected without any eggs inside. What test would you suggest?
Sure. Well, I like to believe that that was probably unlucky. I mean, of course, AMH of 0.47 is very low even for a 38-year-old. On the other hand, 4 follicles is a good thing. It happens. You know, I have to admit. Today I had 0 eggs from 2 follicles on someone more or less your age. I would do some baseline tests just to make sure for some essential factors like hormones, a little bit of genetics, karyotype, cystic fibrosis, some male tests. I would take some vitamins for both of you, vitamin D. In my practice, I like to see vitamin D levels over 50. Most people think it's okay if it's around 25. It's not okay. So I try to optimize as much as you can. Exercise if you can. Make sure you lead a healthy lifestyle, and try again. I mean, have a look at the protocol, discuss with the doctors. I always like to hang on to the positive facts. So you've conceived naturally, which means that you have been fertile. It seems that there's tubal factor there, definitely. Ectopic means that one tube is perhaps not functioning properly. With one ectopic, it's very likely that the other tube is perhaps not perfect. Plus the cesarean section, which may have affected a little bit the tubes further, if not the uterus, if not both. I think you're on the right track, having IVFs at 38. Take some vitamin D, check for some levels, healthy lifestyle, perinatal vitamins, consider DHEA. DHEA may help a little in the yield of oocytes, and have very careful monitoring of the cycle. I mean, there's a lot of reasons why you may have had an empty egg, empty follicles. The most common reason is bad cycle, but also it could be bad timing. It could be ovulating too early or too late. There's a lot of potential factors. Sometimes also cycles can be unpredictable. Unless we monitor every day, especially towards the trigger day in IVF, for example, unless we monitor day 8, day 9, day 10 every day, sometimes in my practice we monitor twice a day, just to ensure that we don't miss the window of trigger and all that. So my feeling is that you will get some eggs. So, keep going. You will get some eggs, get the timing right. Perhaps try a little different dose of stimulation. If you had full stimulation, try a milder stimulation next time. And I'm pretty sure you will achieve that.
Brilliant. Thank you so much. Thank you. I will go to the question from Jenny because she did send a follow-up. So thank you for previous advice. Is treatment worth pursuing after 2 natural pregnancies? Lab blood tests indicate very low B and T cells. Anything you can advise here?
Yeah, anything could work. I mean, the thing is that it's very difficult to set up a study with cases like yours. Anything could work. The question is what is giving you the better chance and the quickest chance, and especially in view of your age. I mean, at 40, between 40 and 41, it would be best to give yourself the best possible chance. If I want to be very frank, I'm not convinced with the science behind lymphocyte immunotherapy, if that's what you mean by lead. I'm not convinced by the science. That's why I don't very often offer it in my practice. As I said to you before, I think the quickest road to pregnancy would be IVF with PGTA testing.
Okay, thank you. Crystal clear, I think. Thank you so much for that. Let's have a look. Next question. Hello, how does clotting screening test affect IVF? I have slight high range of PTT 70 seconds. You can see it. I'm not familiar with that. Should we go for IVF process or better to investigate the underlying condition? Sure.
Okay. Thank you, Vic. I have huge interest in hematology, I must admit. and this essentially comes from the fact that I didn't used to understand most of it. And my team and I we had invited in the past one of the world's famous professors from France, and he stayed with us for a few months. And this is when we were really shocked to understand how little we knew about clotting, about thrombophilus, and so forth. The short answer is that thrombophilia is not a it's like weather. It's not always the same. I mean, they say Greece has good weather. Now we have storms outside. It's not. So thrombophilia can be affected. The thrombotic potential can be affected by many factors. And so I don't think we should disregard that. So since you have discovered that tendency, that marker, I would probably suggest you have full investigation of thrombophilia. Now, thrombophilia is two types, as you probably know, is the congenital, what we're born with, and it's the acquired. The good thing about congenital is that you do the tests once, you don't have to repeat them. The bad thing about the acquired ones is that the tests are valid for about 6 months to a year. So I would suggest you have full investigations and then try to stratify the risk of thrombosis you have. And of course, bear in mind, and this is a very clear message to all of you listening in, that even a mild tendency may become a big tendency if there's a couple of confounding factors. For example, estrogen treatment and a small infection, or estrogen treatment, small infection, obesity, and perhaps lying in bed thinking that, oh, if I lie in bed for 2 weeks, the implantation may be better, which is not. So personally, because this is the thrombosis is the bullet that kills you before you hear it, I am very wary, and I'm very much afraid of thrombosis. We had some kids here. We had some tests with a French professor that showed us that really most of the tests we do are very, very, at best, very gross. There's some more specific tests. There's tests we can do today to see what is our thrombotic risk today. And many of those results contradict the baseline and the background risk, if you like. So very complex. Please do not ignore it. Go ahead and investigate fully. And if in doubt, in my practice, I love low molecular weight heparin, I have to say, and I love it for 3 reasons. One is that it's generally inexpensive. 2 is that generally it has very little, if any, side effects. 3 is that apart from the antithrombotic effect, it has also an anti-inflammatory effect. And 4, in my 30 plus year practice, with about 20,000 treated women with major surgery and IVF, I'm very proudly presenting that I've had 0 cases of thrombosis. I repeat, 0. That means that I'm probably giving over the top low molecular weight heparin, but we all know that with high-risk patients that we're treating every day through IVF and through complex surgery, the accepted risk, the accepted thrombosis complication can be as high as 2, 3, or 5%. So 0% in 20,000 means something, and I'm very happy for that.
Yeah, thank you. Thank you so much for sharing, of course, as well. And let's have a look. More questions are coming in. In the case of treatment with donor eggs, what treatment protocol would you recommend for a 40-year-old male with low sperm motility, 40%, and low testosterone level? Would 𝐾𝐶 be an effective option in this case? Additionally, are there specific genetic or chromosomal factors you assess when the male partner is of advanced age? What genetic testing would you recommend before proceeding?
Thank you so much, Luca. I mean, this is very much to the point. Okay, I'll give you my list now. Semen analysis, semen culture, DFI testing. That's on sperm. General biochemistry, so thyroid, prolactin, sugar, diabetes, HbA1c, vitamin D, and a little bit of a lipid profile. Genetic test, karyotype and cystic fibrosis, checking for 99% of the genes. Yeah, this is my standard investigation. Of course, together with the viral testing, which is obligatory by law. And thalassemia electrophoresis I do on everyone, simply because we're all mixed. So in the old times, they used to say, oh, you're not of Mediterranean origin. How do we know? How do we know? We don't know is the answer. So it's, again, a genetic test, very inexpensive. You do it once forever, and you get a lot of ideas. So by doing all of this, if I identify any factors, I would probably optimize those before using the sperm. But generally, we don't have a big problem treating with egg donation with a man with those characteristics. And of course, the best indicator, the best key performance index, if you like, of the male is the number, the quality of the blastocysts. So if we have good blastulation rate of perhaps 4 to 5% from the oocytes, that is a sign that we've done good work on the male factor, and of course that the male factor has not adversely affected our fertilization. And of course, I would use 𝐬𝐮𝐬𝐜, yeah.
Okay, sounds good. Thank you so much for that. And let's have a look. Sorry, I'm just, yeah, there's a thank you from a patient here. So thanks a lot for your question as well. And let's have a look. Next question here. I'm 43 with 3 early miscarriages. After investigations on female side, nothing was found. Male factor not yet checked, but he has a 16-year-old AMH 9.7, 𝐾𝐨𝐧'𝐭 and high TPO. Any advice here?
Sure. I mean, at 43, miscarriages are usually chromosome related. So I would be very skeptical on what you've said about nothing found as cause. I have this saying, which is not very popular many times with our patients, is that none of us is healthy. We're not properly investigated. You know, if we're investigated, we will find that there is something there. So at 43, I think it's very important to rule out from your side as much as you can. Now, someone who's had who was fertile 60 years ago doesn't really mean very much, I'm afraid, because 16 years is a lot of time. It's like someone checking their thyroid 16 years ago and finding it normal. It doesn't guarantee that 16 years down the line is going to still be normal. So I would thoroughly investigate the male, and both of you. I mean, at Embryoclinic, we have a very specific recurrent implantation failure protocol, and also we have a miscarriage, natural conception protocol. So I would probably employ most of those, both of those protocols in your case. And also bear in mind that at 43, there's a little bit of a limited time. I don't want to stress anyone, but if you are to resort to artificial technology, perhaps now this is the time. And again, as I said previously to our question, try to use PGTA as well, because that would ensure at least that the embryo is DNA normal. A DNA normal embryo doesn't mean 100% is going to implant, but at least it takes away the most important factor of implantation failure and miscarriage.
Okay, again, thank you. Thank you so much for that. We will have a question from David. Okay, I think you are familiar with David. So as we more towards more investigations of the male, is there now a need for fertility units to have a specialist andrology lab?
Sure, thank you so much, David. I mean, for those who don't know, David Gibbon is one of the leading embryologists in the UK. I have had the privilege to work with him many years in England. We shared a lot of happy times, a lot of disappointments also, and he has always been there supporting all of us, doctors, biologists, all over the world. I mean, he is a gem of a guy, and also supporting patients. So thank you so much. Yes, this is something I probably missed in my presentation. Absolutely yes is the answer. A specialized andrology lab goes without saying that should be working side by side with an IVF unit. If I want to make it a little bit more clear for perhaps the audience who are not very familiar with the difference, traditionally embryologists were dealing mainly with oocytes, and they presumed, and they were right in many cases, if not in most cases, but definitely not in all cases, that sperm we can manipulate and just inject it into the egg, and it doesn't matter so much if it's not perfect. Now, in the last perhaps 10, 15, 20 years, we know that it matters. So embryology and andrology is like a gynecologist and urologist. We know a lot about. We gynecologists know a lot about sperms and about men and about male. In my times, we used to perform even surgery on men. It was allowed on the NHS. I'm not sure if it's still allowed, but andrologists know better. So they know much better. So I think we have to accept that both in the clinical aspect, we need the urologists, andrology specialists, and also in the laboratory field, we need specialized biologists, biochemists, geneticians in male infertility. And I can very proudly share with you that my team and I, we have set up recently a sperm clinic, which is dedicated in andrology and in male factor infertility, and not just infertility, because the sperm is a mirror of the general male health. Let's not forget that.
All right, perfect. Thank you so much for your question. We will be slowly finishing, so if there are any other questions, go ahead, type those in, and we have a student here that would like to ask you. Wanted to ask if there are preventative measures to reduce the risk of secondary infertility after childbirth, and also which tests are prioritized when evaluating. Sorry.
That is a wonderful question. Preventative methods. Well, I think naturally making sure that pregnancy and delivery are uncomplicated. So avoiding unnecessary interventions if possible. If there's any complications, address and treat them properly. And for me, the most important is not to allow a huge interval between pregnancies. Because even at 33, 35, 37, there is an effect of age on the fertility. Now, how we prioritize tests, again, I can share a little bit of our secret. We have one-step fertility clinic for those patients. One step, one visit, 1 hour. In 1 hour, we take the clinical history, we do a 3D, 4D ultrasound scan on the woman. At the same time, the man is giving sperm. During that time, the embryologists, they check for semen analysis, they send off culture and DFI. And at the same time, we do a high FOSI, a high resolution ultrasound scan, salpingography on the woman, and we draw some blood for hormonal tests, AMH, and some basic genetic investigations. The whole visit lasts for 1 hour. The cost is very reasonable, and then we have either a video call follow-up within 2 weeks, or we have a second follow-up, and we have addressed 90% of the potential causes. So one-step fertility clinic. That's I think that's the answer to your question.
Okay, sounds good. Thank you so much. And actually, we do have another question again from a student. So thanks a lot for joining us today.
Yeah,
the question is, yes, you can see it, right? I had a question that how often do serious underlying health conditions cause secondary infertility that we were missed during the first pregnancy?
Of course, yeah, many times indeed. I mean, if I can make a list, I mean, I've had a woman with a unicorn uterus, half a uterus, who delivered early her first child, and then she could not conceive, and she had lots of miscarriages. I've had many cases with complete diaphragms who've had the first cesarean section. Nobody understood what was going on. Simply because she was lucky and the pregnancy developed in one side of the uterus and then pushed the other one away. And then at the time of cesarean section, they didn't realize there was a diaphragm. I've had cases with severe male factor infertility who got lucky. Perhaps they found a window of implantation there. So there's a lot of reasons. Sometimes there's a lot of reasons that that someone gets lucky, and a lot of reasons they get unlucky later on. But one very important question to ask clinically is how long did it take you to conceive the first child? Usually, couples and women with primary infertility, they've had trouble conceiving the first child. It took them 5, 6, 7 years. If I can give you some figures, the chance of conceiving, for a normal couple, the chance of conceiving naturally within 2 years is probably 90%. But then after 2 years, every month they only have 3% chance, 3%. So someone can win with a losing hand, and then later they lose with a winning hand. So it's not uncommon.
Okay, thank you. Thank you so much for your questions. I think that was our final question for today. So thanks everyone for your questions. Thank you for joining. I do believe it was useful and very informative for you, Dr. Tsakos. It's always great to have you. So thank you so much for today. Any final words before we finish?
All I can say is that the majority of secondary infertility patients, they're more motivated. And this may be very frustrating for some of you in the audience who are struggling for the first child, but the majority are even more motivated. They're crazy. They really want it. They're amazing people. I get a lot of positive feedback from them. I'll get a lot of courage. They get a lot of my admiration. They want a child because they have experienced the joy of having one child, and they're willing to go as far as they should go in order to achieve that. And I find that they achieve egg donation easier than the couples who haven't got a single child. That's number one. Number two is that unfortunately, most of them, they delay coming to the doctor because they have their first child. They enjoy the child for a couple of years, 3 years, 4 years. Child goes to school, and then they start a little bit natural efforts. Before they know, the 7, 8, 10 years down the line, and the woman is in her 40s, and of course, even if there's no other factor, just the age factor alone makes things difficult. And from those couples, many of them, they don't come forward. So I think it's a shame, because many of them would have a very easy solution, if you like, in the management. So I think it's a very specialized group, and thank you and congratulations, Caroline, and the Fertility Society for bringing this topic forward. Secondary infertility is very common. I think it affects most couples, especially if we add on to those to that category, the couples who achieved a pregnancy but not a delivery and had a miscarriage. I think that affects a lot of people, and we are out there to help them. There's a lot of resources. Please don't hesitate to drop us a line, and my team and I would be more than happy to help you.
Definitely. Thank you so much indeed, everyone. It was great to have you, as I mentioned before. Thanks for joining. Have a lovely evening. And of course, we will be back with some more events. So stay tuned. You can go to my MVF&x.com website and you will find all upcoming events there. And of course, I will definitely see you soon, Dr. Tsakos. So take care, everyone. Bye.
Good night. Bye-bye.